how life is good. So it's my pleasure to introduce Dr. Peter Black. Peter is a urologic oncologist at Vancouver General. He's a research scientist at the Vancouver Prostate Center and an assistant professor in the Department of Urological Oncology at, I'm sorry, I skipped something here, at Urologic Sciences at the University of British Columbia. He completed his urologic training at the University of Washington in Seattle and did a fellowship in urologic oncology at MD Anderson in Houston, Texas. He treats primarily kidney cancer, bladder, and prostate, and has a lab research program related to these urological cancers. So it's my pleasure to introduce Dr. Black.
Okay, terrific. Thank you for the introduction, and welcome everybody, also everybody online. I think our crowd online is bigger than here in person, but the combination is important. So I'm going to talk a little bit about surgical management of kidney disease. There's a lot to talk about. It's a very surgical disease. Dr. Kohlmannsberger, I think, would even agree with me. He's sort of a hidden surgeon in a medical oncologist's body. So when we look at the timeline of the evolution of kidney cancer and how we describe kidney cancer, how we diagnose kidney cancer, there's really a lot has happened over the last 30 years or so on the top line there. And when we look at the bottom line, we see that a lot has also happened with the surgical management of kidney cancer. We have the radical nephrectomy. I was just talking to Susan Robson, our host, beforehand, asking her if she's related to the Charles Robson who described the surgery, because he's also a Toronto native, but unfortunately not. But we, in the 80s, we moved towards partial nephrectomies, where we're actually saving the kidney, just removing the tumor. We moved to laparoscopy. We recognized that removing the kidney in metastatic patients is valuable, so we call that cytoreductive nephrectomy. And then more recently, we've actually moved to active surveillance, where we don't treat small tumors, and we have ablation methods where we can burn or cool tumors. And so I'm going to go over some of these specific treatment options that we have. In general, we can think of the different scenarios a patient might be in that we're treating. So we have either localized disease or advanced kidney cancer. And if it's localized, we're always thinking, are we going to save the kidney and do a partial nephrectomy, or are we going to remove the kidney and do a radical nephrectomy? If we're going to save the kidney, is it going to be still cutting the tumor out, or are we going to ablate with the cryo or radiofrequency ablation? And then advanced disease, as I mentioned, we do take the kidney out in some metastatic patients. We also go back and do more surgery sometimes if the cancers come back after removing the kidney. And we even sometimes remove metastases. So if a patient has a single spot in the lung or a single spot in the liver, for example, we sometimes remove that. So there's a lot of surgery goes on in kidney cancer patients. The classic operation, the radical nephrectomy, was described, I think, in the 60s. And it includes taking the kidney, all the fat around the kidney, the adrenal gland, which sits just not quite like this, but sort of on top of the kidney. And we just come across the vessels, we come across the ureter, and we remove as much as possible just to make sure we get everything. We used to do it, well, when we remove the kidney, the pathologist looks at it carefully. They describe how extensive the tumor is it limited to the kidney or not. The grade, there are different grades which tell how aggressive it is under the microscope. And also there are different patterns of histology, so it can be a different type of tumor depending on what it looks like under the microscope. And those are all very important things for determining treatment and predicting how a patient's going to do. One special type, as I've alluded to, is actually removing the kidney despite metastases. And we do this particularly in healthier patients, young or old, but healthier, and patients who do not have too much spread to other sites. We want really, if we're going to be removing the kidney in patients with metastatic kidney cancer, it has to be the vast majority of the tumor that we're removing in the kidney. We recognize that it does not cure the disease, but we know from older studies that it does help improve the outcome. And so that's something that typically I would see a patient and I would discuss it with Dr. Kohlmannsberger, and we would come up with a plan who needs drugs first, drugs like sunitinib, and who needs surgery first. When we're doing the surgery, we used to do all surgery open, of course, through incisions, often in the flank, around the ribs, which can be fairly painful, sometimes also in the front, in the middle. Not often, sometimes we still have to do open surgeries. Not everybody is amenable for the new way of doing it, which of course is laparoscopically, keyhole surgery, where you make small holes and you put a camera in. We do this whenever possible, but not everybody is amenable. Of course, we wish all our patients were this skinny, but you can see afterwards they're barely noticeable scars. We do generally, you can see down at the bottom here, there's sort of a bikini incision. We do generally make one hole big enough that we can get the kidney out in one piece. We don't want to break it up before removing it. We want the pathologist to look at it completely and tell us exactly what's there. Some patients are not able to have it done laparoscopically. Often, for example, if a patient has very bad lung disease, then we can't fill the abdomen up with the carbon dioxide that we need to create the space to work and still be able to ventilate the lungs. So that's sometimes an issue. Or some patients, of course, are very large, but generally we can still do it. Sometimes the tumors are too large, or the tumor grows into the renal vein, the vein that comes from the kidney, or even into the vena cava, the big vein that goes back to the heart. So sometimes we have to do it open. The other end of the scale is a new sort of fashionable way of doing it called single port laparoscopy, where you have one hole, usually right at the belly button. It ends up being a fairly big hole, so you can get multiple instruments in. It is technically very difficult. It hasn't really caught on. Some people have done it to write a paper saying they can do it, but it's not something that anybody is really doing routinely for removing kidneys. But as technology improves, and if you link this to a robot, for example, it's something we may be doing in the future. The advantage, of course, is really just cosmesis and recovery time. Now, for removing a whole kidney, the logical question, of course, is what happens to my kidney function if you take out a kidney? Is the other one going to be enough? And the vast majority of patients will not need any dialysis, and their kidney function will be adequate if they only have one kidney left. But we recognize that even a loss of kidney function that doesn't make a patient sick, they go on about their daily business and don't really notice a difference, that it does lead to other health concerns, and in particular cardiovascular health. So we know that the risk of things like heart attacks is increased in patients with reduced kidney function, even if it's not concerning enough that we're even thinking about dialysis. So we like to preserve renal function, kidney function whenever we can. Just an aside on how we define kidney function, I think everybody in the room probably knows, and everybody online is familiar with these parameters, but we go by the serum creatinine. So the creatinine is something that's made by muscle. It's released at a fairly constant rate into the blood and filtered and secreted by the kidney at a fairly constant rate. So that level in the blood gives us a good indication of kidney function. The other number is the estimated GFR, glomerular filtration rate, which actually takes the creatinine and sort of corrects it using a patient's gender, their age, and their body weight. And so it's a little more accurate, more accurate measure of function, although it is ultimately based on that same creatinine. The confusing thing, I think, for patients is that normal in both cases is around 100. The creatinine, you want it to be low, but the eGFR, you want it to be high. So, but patients, of course, learn that very quickly. So if a patient has an eGFR that goes down below 60 after surgery, 60 is normal for older adults, then they're not going to notice a difference, but it may have a negative impact on their cardiovascular health. So we really try to do what we can to preserve kidney function. And the way we do that, of course, is with partial nephrectomies and the ablation procedures. So what is a partial nephrectomy? A partial nephrectomy is surgical removal of the tumor only and leaving the kidney behind. We can do it open, we can do it laparoscopically. A lot of places are doing it robotically. The idea is that you just cut out the tumor and just a very thin rim of normal kidney, and then you sew up the defect in the kidney. And you essentially have preserved almost 100% of that kidney. The only thing that's gone is the tumor. The only real, the main risks involved are just bleeding because you're cutting into a very bloody organ. And of course, it was a big step to take back in the 80s that people thought you could get away with this and not cause the cancer to come back. Robotic is sort of becoming the most common route of doing it in the US. In Canada, we're still doing a lot of open and laparoscopic because the robots are not quite as ubiquitous as in the US. And of course, this is also heading the route of single port surgery as technologies advance. So who gets a partial nephrectomy? Well, we used to talk, we still talk a little bit about absolute, relative, and elective indication. Absolute means you don't have an option. If you want to remove the tumor, you either remove the kidney and put the patient on dialysis, or you just remove the tumor. So any patient who has just one kidney, of course, sometimes the other kidney's been lost to kidney cancer, and this is another tumor. A patient who has tumors on both sides at the same time, you can't just go in and take, well, you can go in and take out both, but a patient goes on dialysis. And then patients who have renal kidney function that's bad enough, if you removed one kidney, you would almost certainly put them in dialysis. And then we talk a lot about patients where we think the kidney function is going to be at risk longer term. So if a patient has diabetes and high blood pressure, in particular, those are things we see very frequently, then we might be concerned that the renal function is going to decline over time. So we would like to preserve the kidney as best we can. An elective is something we do an awful lot these days, which is basically any patient, regardless of health status, if the tumor is 4 centimeters or less, generally first choice is a partial nephrectomy. And over the last few years, the indications have expanded that we're doing it a lot for larger tumors as well. In a lot of people's hands, especially at academic centers, if a tumor can technically be removed without removing the kidney, then it is offered that way. I'm not sure if pushing it to the extremes really makes sense from a cancer point of view. 4 centimeters is one of these magic cutoffs. There's a lot of literature, a lot of patients have been treated, and we know that patients who have the partial nephrectomy for a tumor less than 4 centimeters do very well. And if it's bigger than 4 centimeters, it depends a little bit on the tumor, and patients do less well, but also still very well. Unfortunately, although we've known this now for a long time, there's still a lot of radical nephrectomies done around North America where really partial nephrectomies would be the better choice. This is something that is slowly evolving. To some degree, you have to wait for the old guys to retire so the young guys can come along and start doing it the way we think is better. And I know Kidney Cancer Canada a few years ago, in National Kidney Month, which for Kidney Cancer Canada is National Kidney Cancer Month, the big message that we're trying to get out was that partial nephrectomy should be pushed more. And if your urologist is talking to you about radical nephrectomy, maybe ask for another opinion to talk about partial nephrectomy. Having said that, some patients certainly still need the radical. So this would be the typical small renal mass that we'd be considering for partial. And a bigger issue is how important these masses are. Do all of these masses really need to be treated? Because we're diagnosing more and more of these as patients get ultrasounds and CT scans for other reasons. It's hard to get out of an emergency room these days without having a CT scan. And so we're finding a lot of what we call incidental renal masses. And you know, the natural thing is to make the diagnosis and then treat it. But you can see here 70% of masses are incidental, which is a huge number. We know that at least 20% so if you take 4 as a cutoff, then about 20% of them are benign. If you take 3 as a cutoff, it goes up to 30%. If you take 1 as a cutoff, it's higher than 40%. So the smaller it is, the more likely it is benign. The smaller tumors are almost never metastatic, so we always have time to keep an eye on them. And about half of them are clear cell kidney. One of the points I thought was going to come up on that slide is that we know, although we're diagnosing all these small renal masses, we have not made a dent in survival from kidney cancer in this regard, which implies that if we're diagnosing them early, and then treating them earlier, but survival is not improving, then a lot of those renal masses do not need to be treated. So we need to be very careful in that regard. So the question is, what else can we do? I mean, a partial nephrectomy is still a fairly invasive surgery, even if we're doing it laparoscopically. We're still cutting into the kidney. There's a risk of bleeding, a risk of urine leakage, risk of losing the kidney. So there's always the interest in doing something less aggressive, less invasive. This is particularly so in older patients, patients who may, for other reasons, not be expected to live as long. Some patients refuse surgery. Some are just not really suitable for surgery. Some patients have familial diseases like von Hippel-Lindau, where you know they're going to come back with more tumors in the future, and you don't necessarily want to be doing surgery over and over again. It becomes more complicated every time. And that's where cryoablation and radiofrequency ablation comes in. These are procedures that we can do. In the past, we've done a lot of them laparoscopically, like you can see here, where you're actually looking in at the kidney with a camera and putting the probe, which is freezing the tumor, right into the tumor under direct vision. This shows that you have an ultrasound probe in behind the kidney that is showing the ice ball develop around the kidney tumor. This is what it really looks like, different shades of gray. But you can also do this percutaneously. So you put the probe straight into the tumor, just through the skin under CT or ultrasound guidance. And that's really the most or the least invasive way of doing it. And again, some institutions have reported many patients have been treated this way, and the results are really quite good. Here's a review of 450 patients, for example, and only 18 had a recurrence, which is a fairly small number. And the complication rate also was very good. Radiofrequency ablation is very similar, but different technology. Here right from the beginning, this has mostly been done percutaneously. You can see in this CT scan that the needle is being introduced through the back. These are the muscles in the back. This is the spine. And over here you have the kidney tumor, more up here actually. And you can see that this device has these prongs that are deployed, and then the tumor is heated, cooled, and the actually I take it back. With the cryoablation, it's frozen, thawed. Here it's just heated, and the high temperature denatures the protein and kills the tumor. And there are also lots of series. Here's a similar number. The other was 450. This is 390, and interestingly, almost the same number of recurrences over the short term. You can certainly, as this bottom line indicates, if you do it in the wrong patient, you can cause problems. So if the tumor is right close to where the ureter goes off the kidney and the ureter gets heated, you'll have a lot of problems. So again, not every patient is suitable for either of these technologies. This shows you an example of a tumor here. This is right next to the liver up top. So this is on the sort of the front and the side of the kidney. This is with the needles going into it from the RFA probe. And then this is a year later. You see there's still something there. The tumor doesn't just vanish, but clearly it's dark gray, which means there's no blood flow, while the rest of the kidney is whitish, indicating good blood flow. One of the challenges with these technologies is knowing whether the tumor is actually gone or not, because there's always something left, or at least there is for several years. And so all we have to go by is this lack of blood flow. So the results look pretty good, and we're not too tentative in offering this to the appropriate patients. But if patients are younger, healthier, we generally would prefer to do a partial nephrectomy because it's more definitive. The results are even better. There's a lower risk of recurrence. You also have to bear in mind that the people who publish big studies on this do a ton of it. They do an awful lot of cases, and their results tend to be better than somewhere where you don't do as much of it. So you can't necessarily reproduce low recurrence rates everywhere. Surgically, I think it is more reliable. So we generally keep this for patients who either refuse to have surgery or are not that fit for surgery. So now one step less invasive is, so we went from radical to partial, from partial to ablation, and now of course one step less invasive is just surveillance. And this is actually the point I was making, that we're detecting more and more kidney cancer, but we haven't really put a dent in survival this thing, we have put a dent in survival maybe with the treatment of advanced kidney cancer, but I don't think that all this early diagnosis is making a difference. And in fact, we're at risk of over-treating. So one of the solutions to over-treating, and this is something we do a lot of in prostate cancer, for example. It's very important in prostate cancer. It's a huge issue, over-treatment. And so a lot of us who do kidney cancer also do prostate cancer, and so you can sort of compare strategies. And so we're very used to the idea of monitoring a cancer, which 10 to 15 years ago was not really an acceptable idea, but it is acceptable to monitor kidney cancer. The difference with kidney and prostate is that we're less confident in kidney cancer than we are in prostate cancer about who really has a harmless tumor. A small kidney tumor can be small and stay small, or it may just be the beginning of something aggressive, and we just happen to really catch it early. So we don't know that. Overall, though, most of these tumors grow very slowly. They probably will never grow significantly. They will never metastasize, and they can really just be left alone. But we're not quite sure at this point which ones are safe to watch. So there are series out there. There was a Canadian multi-center study led by Mike Jewett in Toronto, and we participated and others participated. And there are more than 100 patients, and the patients certainly short-term have done very well, but we need to see how they do longer-term. The fact that a tumor doesn't grow in 1 or 2 years, that's one thing, but a lot of patients live a lot longer than that, of course, and so we need to be sure that it's not going to grow after 5 to 10 years. And you can see this is a large study from the Cleveland Clinic. Cleveland Clinic's one of the leading kidney cancer places, and they only followed patients for on average 24 months. And that's just not long enough to be convinced that this is a good thing to do. You can see, though, that the average tumor growth is just 0.26 centimeters, right? That's not very much. If you're talking about a 3 or 4 centimeter tumor, just less than half did not grow at all in that relatively short time frame. So, clearly a lot of these tumors are not destined to be bad. One problem is that even benign tumors grow, and they grow just as much as the malignant tumors in a lot of cases, so growth by itself is not the best measure. And of course, every now and then a small renal mass does metastasize, and every now and then we remove it and we see that it is invading the fat or it is invading the vein, so we just need to be careful. If we are doing active surveillance, the question is, how do we follow patients? Do we do CT scans all the time, which of course introduces radiation? Do we do ultrasounds, which is nice and easy and relatively inexpensive, but are you actually seeing it well enough? When do we intervene? At what size or what growth speed? How old or how young should patients be? Do we biopsy tumors before? I don't think I have anything else in here about biopsies, but biopsy of kidney tumors is becoming more and more popular. We didn't used to do it because we didn't really believe the results. So if we did a biopsy and it showed cancer, we said, okay, we need to treat it. If we did a biopsy and it didn't show cancer, we said, okay, we don't believe it, and we treat it anyway. So that, of course, is not very rational, but the techniques for biopsy have gotten better. They get better samples, bigger chunks of tissue, and the pathologists are better at looking at it. So in most cases, we can make a diagnosis, although it again comes back to one of these issues that it works well if people are doing a lot of it. It doesn't work well if you're in a community hospital where someone's doing it once every year or so. So you have to be careful on how sort of these practice-changing algorithms are used. But now if we get a biopsy and it says it's benign, we will not treat the tumor. So just in summary, we talked about radical nephrectomy, which is the gold standard, but is often overkill. And so we would consider the partial nephrectomy as an alternative gold standard. And some would say for smaller tumors is the real gold standard. How it is done is secondary. I always emphasize this to patients. If we can do it laparoscopically, great, but the emphasis should be on doing the partial nephrectomy. So if the surgeon thinks it's going to be too hard laparoscopically and want to do it open, that is still better than doing a laparoscopic radical nephrectomy. And if the surgeon says, oh, well, I'll try and do a laparoscopic partial, but if it gets difficult, I'm just going to do a radical, That, I think, is the wrong strategy. The change of plan should be to open and finish the surgery as a partial and not do the radical. And then RFA and cryo are still have relatively limited use, but we are doing them on a regular basis. Every week we're doing RFA and cryo. I should say ultimately that it's really dealer's choice. It's up to the treating radiologist or urologist to decide which one they prefer. We can't really say that one's better than the other. And active surveillance is something that we routinely use in older patients or those with more health concerns.